Hey folks, welcome to the Paindora Podcast. This is your host, Dr. Kevin, and I'm here today with my co-host, Dr. Cady, Dr. Melissa Cady, the Challenge Doctor. And for today's episode, we're going to be talking about really myths and misconceptions about the science of pain or pain science. And specifically, we're going to be talking about an article, a classic article, quite often referred, at least in the pain science community, by I don't know how to, I don't want to use the word guru because I don't want to insult anybody with that because I know we get used too much, but really some
experts.
How about the godfathers of modern pain science? Godfathers of pain science. And that would be Doctors Lorimer, Moseley, and David Butler. Fantastic people are doing amazing work. And they published a paper 5 years ago now called 15 Years of Explaining Pain, the Past, the Present, and the Future. And in this particular article, which is, I think everybody who has an interest in pain should read, which means that if you're in healthcare, you should probably read this. They're really reconceptualizing pain care, going back and talking about the misconceptions that have been going since at least the 60s, really since the initial publication of gate control in 1965, and how that stuff was misconceived and how that has altered the care pathway of how we treat pain. And they've been involved in pain neuroscience education for decades now. Quite a difficult process, which I take heart in, knowing how difficult it has been for us. I know for you, Dr. Cady, it's been difficult as well. But they went through some really difficult times when you're trying to bring about this new paradigm shift. When it's like, how do we align clinical practice with what pain neuroscience shows? And in that, just like any time that you're bringing about a new idea, there's a miscommunication that occurs. And in this is when people are talking about explaining pain, what tends to occur is people think that pain science somehow is a therapy, or that we can like poke them with the pain science in some way, like you're applying the pain science. And pain science isn't a technique per se. Instead, what it is it's an understanding, it's a structural framework, it's a way that you can deliver care through, but it's not a technique. Again, you can't poke anybody with pain science. So I think, Dr. Cady, what we were going to do is just kind of go over shortly the myths and misconceptions that they had identified early on between what pain science and education around pain science is and what people tend to believe and what the facts are.
Yes, and I do believe it's an informed perspective is, a lot of this understanding of pain science. And I'm going to share with the audience a table that's taken from that article, and let us look at the let's see if we can pull that up. Can you see that?
You are a technological genius. Look at that.
Oh, look at that. So there's a list on the left side of misconceptions, and then what Lorimer, Moseley, and David Butler intended, the more accurate conceptions, are on the right. So we're going to go through each of these one by one and maybe have a little commentary off of them. But one of the misconceptions is, and EP stands for Explain Pain, which is one of their great books. They have Explain Pain Supercharged, which is really great too. And we don't make any money off of saying that, but it is a good resource.
We should make money off of saying it.
That's right. But the first misconception is that Explain Pain is teaching people how to manage their pain, similar to, for example, coping skills training, relaxation training, goal setting, or problem solving skills. The more accurate conception is that Explain Pain is teaching people about the biological processes underpinning pain. It does not include instructions on strategies or skills with which to reduce the impact of pain in one's life. And Explain Pain draws on instructional design and multimedia principles to present pain biology information. Your thoughts?
Well, obviously I completely agree with this, but I think that is a persistent misconception, mainly on the way that we are focused. Like, again, people think that you fix pain rather than facilitate change. And again, when it comes to like pain science or pain neuroscience education or explain pain education, delivering education is not about talking. And it's not saying you're replacing a care model or is it replacing one technique or tool with another one. Instead, what what education does is it does two things. One, for the clinician, it informs how you deliver care. So it's like understanding germ theory when you are treating an infectious disease. From a patient perspective, providing you information, educating you about pain is not delivering an antibiotic, but it's teaching about hand washing skills, healthy hygiene, how all of this stuff works. So that in an ideal scenario, you can then take that knowledge and apply it through self-engagement or self-strategies. Again, if you know about infectious disease or germ theory, aka that would be the equivalent for pain education or pain science, now you may need antibiotics, depending on the scenario, which you're going to get prescriptions from your clinician. But you can also wash your hands. You can do making sure you rest. You can do all those other things that's going to treat that infection in addition, because you know the process that's involved.
So let's just pin that into today and mark the obvious year with coronavirus. It's like just assuming just because you're exposed to a virus that you will get infected. And we know that there are multiple elements of biology involved in order to actually get an infection or to be symptomatic and all of those things. So there's a biological complexity. What are you laughing about?
Well, like what we should do is we should take this chart and we'll replace the coronavirus, right? Instead of explaining pain, we're going to talk explain coronavirus. So like if we said the misconception would be explaining coronavirus is teaching people how to manage the coronavirus, similar to, for example, coping skills training, relaxation training, goal setting, or problem solving skills, right? And explaining coronavirus does not treat coronavirus. Instead, explaining coronavirus is teaching people about the biological processes underpinning viral infections. Explaining coronavirus does not include instructions on strategies or skills with which to reduce the impact of viral infections on one's life. Explaining coronavirus draws on instructional design and multimedia principles to present coronavirus biology information.
Ta-da!
Ta-da!
Exactly. And then there's you can even say there's a lot of fear involved with coronavirus and whatnot. So people can get fearful about getting outside. Well, in this explanation, we're talking about explain pain. Some people get very fearful when they have pain to not move. So explain pain, this misconception here is explain pain is advising people to move despite their pain, but actually explain pain more accurately is teaching people that pain can be overprotective.
And that is a very different message. Because then people say, well, you're telling people to move because of despite having pain. No. Well, then you're telling people to not move because of their pain. And the answer to that is no. What we're doing is we're telling people, how can you move, understanding that your brain is overprotective. So what are the movements that you can do to help you feel comfortable, confident, and safe in your body again? It's a little bit more complex, but it's not that much more complex. But it's being able to take that educational framework and then be able to apply it effectively through a different modality. Again, we're not poking them with the pain science. We're using it when we're delivering care.
Absolutely. I don't even have to say anything to that. That was on point. The third one, the misconceptions, is that explain pain is advising people that pain messages are turned up and down at the spinal cord, but rather the more accurate conception is that explain pain is teaching people that danger messages are turned up and down at the spinal cord. I know you're going to love to hit this one because obviously the messages are not pain down there. The pain is constructed in the brain, and it's just danger message or information that is received by the brain to create the experience of pain.
Yeah, absolutely. I think you did beautifully on that. And the only thing being is different words that people use instead of saying pain messages is anytime you hear people say pain receptors, pain fibers, pain pathways, pain tracks, they're putting this one-to-one, their misconception about what pain fundamentally is, that somehow it's the pain pus traveling down, getting stimulating pain receptors in the pain pus pathways or whatever. And that is definitely not what pain neuroscience is about.
Right. And it's semantics to some people, but
it is not semantics.
Here we come.
And and actually, I'm like right now it clicked. I'm like, I'm gonna have
I
to
need to go look up the definition before
I need to look up semantics, and I need to start
you.
deconstructing that word and making sure the clarity behind it is, because my understanding semantics, it means it doesn't matter, and I bet that's not what semantic actually means.
You want me to read you the definition?
Yeah, tell me the definition.
So, the branch of linguistics and logic concerned with meaning, which that's important there. There are a number of branches and sub-branches of semantics that include formal semantics, which studies the logical aspects of meaning, such as sense, reference, implication, and logical form, or lexical semantics, which studies word meanings and word relations. And then there's conceptual semantics, which studies the cognitive structure of meaning. But it all comes down to meaning.
That's totally relevant. Like,
yes, it does. It is important.
And you're like, absolutely, you're totally right. I cannot believe how on point you are with that, because it is totally true. Because it is crucial, the meaning that we deliver and the message that we provide with the words that we use. Absolutely, right. Semantics it is all about semantics, and semantics is critically important.
Right.
Genius person, you are totally right. It is all about semantics.
Well, the implication for those listening is that when we say about pain messages are turned up and down the spinal cord, or like Dr. Kevin said, that, this pain receptors, that is assuming that pain has already been created at that level. But we know that's not the case. Pain is not constructed there. It's constructed up here. And so I think semantics is important, because the meaning of what we're saying here, it's implying the wrong thing.
Well, so the more you understand pain, then you know that the semantics are critically important to care.
Yes. Amen. All right.
Amen.
So number 4 is explain pain. This is a misconception. Is that describing the pain gate control theory, which is 1965, correct me if I'm wrong.
1965.
And the more accurate conception is that explain pain is teaching people that the brain can turn down the danger message at the spinal cord or central nervous system. I guess they're really kind of coexisting, unless you want to correct me on that.
I think that they're referring to is that gate control was really spinal cord centric in a lot of ways. They mentioned sort of the brain as a large influence on the central nervous system, but at the spinal cord level. And obviously gate control was a starting point. And that level has rise from the spinal cord to really being fundamental in the brain itself. And I think that's what they're sort of mentioning there. And what gate control, and this is all, I think this is fascinating, I've gone back and reread it a number of times, is that gate control is really good. And it has been bastardized. I mean, people who say they're using gate control aren't even using gate control theory. But gate control recognized that there was an influence from the brain at the level of spinal cord that either can facilitate or inhibit sensory information coming from the periphery. And so what explain pain is actually doing is putting that message in greater context of the brain picture, but again, reinforcing this idea that your brain has a critical influence on the influence or dampening of peripheral sensory information at the level of both the central, at the brain, and the spinal cord, and the periphery. So.
Right. We're all one system, but it's again, help that the gate control was kind of the tree level, and it's kind of expanded to the forest, looking at all these things.
And gate control is not, you don't forget gate control.
Right, but it's part of it.
It's part of it. It's not either or. It has some really important implications, but if you're stuck there, and as I said, you're more people that say that, there's nothing more than gate control. They're not actually understand the gate control theory well. But you need to kind of grow beyond that.
Yeah, it's not either or, it's and.
Yeah.
Right. So the next misconception is that explain pain was explaining that central sensitization is causing their pain, and there are no known cures for central sensitization. However, the more accurate conception is that explain pain is teaching people that their danger transmission system can become very sensitive, which can lead to more danger messages, but it is always the brain that decides whether or not to produce pain. So interestingly, your interpretation and meaning of what's going on obviously can influence whether or not that sensitivity ever gets better. Any thoughts on that?
Other than, we dumbify pain so much, particularly in the physician world when it comes to central sensitization. It's like, oh, there's acute pain, and that's nociceptive pain pus. And then we have central sensitization, and somehow that explains all of persistent pain or chronic pain, and that's brain pain pus, and you can't get better. We know you can't get better. So that's not even a misconception about explained pain. That's a misconception about pain, period.
There is a big problem in the medical system of putting limitations even on activity, movement, which just limits patients tremendously. That's a big problem. There's a lot of reasons for that.
And then the semantics between central sensitization is, people use this idea that somehow centralization is a quote unquote disease of chronic pain, but central sensitization can occur in acute scenarios. And in the initial papers are described, I think it's like 3 days after an acute injury. So anyway, that's a total matter of semantics, because the meaning that you are giving that term central sensitization can be quite harmful. And you're telling them not only is that false information, but then you're saying that they can't get, that there's no cure for this, for the false information that you're giving them. What are you doing? So
yeah, it's another diseasifying kind of situation.
Yeah.
Yeah, that it's static, can't change, it's not dynamic, and that the system somehow can't have any influence on it. And there was one other thing. So if you were to tell, so I use, and I'm curious your thoughts here. If someone said peripheral sensitization, I think of like sunburn, things feel more intense when normally it's not.
Peripheral inflammation.
We can go on these terms. Yeah. But they can feed off of each other, or you can have peripheral sensitization. It can lead to central sensitization, but the whole system, regardless of where it is, it can get sensitized in different places, but it also has a capacity to change.
Yep, absolutely.
Yeah,
absolutely.
Okay, so number 1, 2, 3, 4, 5, 6. Explain pain. This is the misconception that explain pain is reassuring people that the pain they perceive to be there is not really there at all. Although the real more accurate conception is that explain pain is reassuring people that their pain is completely real, even although the tissue may not be in danger. So all pain is real. I'm just going to say that, and you can go off on that if you want.
Well, I could go off, but I for me, that makes it's funny because there's somehow people in the pain science community are viewed by others that somehow we think that pain is this big illusion and that somehow it's not real. And I would counter that actually people who have a firm fundamental understanding of the science of pain actually appreciate pain and believe it is more real than the peripheral people do. Because they're the ones that are out there judging and viewing what's legitimate and if this is real pain or unreal pain or whatever. And we're basically, it's pain. All you have to do is ask the person, are they saying it's pain? And it's pain, period. That's what it is.
Right.
And so it's just funny because it's like this projection. Well, you don't think it's real. Well, no, actually, I think all pain is real. All pain is real. And the fact that anyway, it's just weird how that happens. We don't believe in people when we actually believe all pain is real, and that the peripheralists who are out there doing the legitimate, real, physical, whatever, are devaluing and are, because the flip side of what they're not saying is that if there's a legitimate pain, then they're saying that somebody else has illegitimate pain. And I have yet to figure out who has illegitimate pain or whose pain is fake.
Yeah, well, that I always like, my favorite thing to say is the one thing that many people can probably agree on is that whenever you're in pain, you always believe yourself. But anytime someone else having pain, we're probably the first ones to doubt it. There's some doubt.
But I would say I would say if you understand pain, we're the ones who don't doubt.
Yes.
That's the difference. We don't doubt. We totally believe that you're experiencing pain.
Right. Well, it's like, what are you going to say? Oh, they don't look like they're in love. That's not real love. I mean, it's if it's love to them, it's love to them. Like you're not there to judge it. It's just, that's what it is. But, it's another complex phenomenon of the human experience.
Yep. Absolutely. Absolutely.
All right. So the next one here we have is that explain pain, the misconception that is that it is a discrete intervention that can be delivered effectively alongside treatments based on a structural pathology model, which is kind of what you're referring to earlier.
Open with the pain science.
Yes. And then the accurate conception of this would be that explained pain can be effectively provided only under a biopsychosocial paradigm which integrates treatment of peripheral and central nociceptive drivers, which for the audience essentially means that you have to look at the big picture, the whole patient, and you integrate things that make sense with that situation with various things that drive peripheral changes or central changes, or essentially they're talking to each other anyway. It affects the whole system. Any thoughts on that?
Yeah, it's basically, again, you don't poke people with the pain science. Instead, science is the framework through which you deliver your interventions through. And interventions I'm saying is how you are influencing or impacting another human being, not like you're poking them with a needle or something like that. And I think that's really crucial to understand, is because if that structural framework and understanding, it's like saying, if you believe germ theory, you're going to wash your hands, you're going to sterilize your instruments. You're not going to
live in fear.
You're not going to live in fear of it. Or even worse, you're not going to say, oh, I believe in germ theory, but then you're not going to wash your left hand because well, the left hand doesn't need to be washed. Or you're not going to wash your sterilizer instruments. Maybe you're only sterilizing instruments that you use, on the leg, but you're not going to sterilize instruments that you use in some other area of the body. I mean, it is completely inconsistent. And it means you're using words and you say that you're using a framework, but you don't understand that framework. Mm-hmm. So, and I do think that's really clear, because there are people who are spouting quote unquote pain science, and maybe their verbal use is okay, but then you look at the words that they're saying and then the actions that they're doing, and they're completely malaligned. There is no congruency there. Even here I was talking to somebody the other day, and there's a pain clinic that says all their staff is trained and explain pain, and yet they're an interventional pain clinic. I'm like, well, how in the hell? I mean, you may have read a book or heard something, but you're not trained in it, because you're delivering your structural framework of understanding. The techniques that you are delivering are not even congruent with that framework of understanding, and you can't. So I guess, and that's what they're referring to, that misconception, that somehow you can say you're explaining pain, but if you're explaining pain while you have a 22 gauge needle in your hand and you're going to go in and inject a facet joint, sorry folks, that is not aligned with that structural that strategic understanding and framework and the science. That intervention is not aligned with that model.
Right. So to dive a little deeper into another misconception, is that explained pain relates only to chronic pain, not acute pain. But the accurate conception would be that explained pain relates to just pain. Pain is pain, period.
Period. And there's a beautiful interview that Lorimer did a couple of years ago. I think it was with the British Rheumatology something. I can't remember. I think it was a Rheumatological Association or whatever. And very briefly, he said, because they were talking about chronic pain. He goes, I hope at some point in the next 5 to 10 years, we're going to see as the conversation is going to stop between acute and chronic, and we're just going to be talking about pain. And that is so huge. And again, if you're understanding pain, you're not saying that there's acute pain and somehow that's fundamentally different from chronic pain. Instead, you're saying that there is simply pain, and there's, we would talk different constructions of pain, and that dramatically changes what you do with people, because you can have somebody that has a quote unquote acute scenario, and how you treat them though is going to be fundamentally different than somebody else in that acute scenario, based on other inputs that are beyond just whether or not the leg is broken. And so that influences your care model across the entire spectrum of care, and not relegating into this isolated scenario when we're having pain that has persisted over some magical number of 3 months or longer.
Right. Well, I think it's kind of silly. In fact, in the book I wrote, I kind of regret even referencing the various types of, acute versus chronic and whatnot, because with the perspective I have now, especially after reading Explain Pain in more detail and Supercharged and just everyone that I've come across to learn more about pain, I'd rather not make that distinction, because, what are we going to do? Call it a 5-day pain or a 3-month pain or a 5-month pain? At some point you got to be like, okay, this is ridiculous. It's just pain, and it's just a matter of timing. And it's still a construction of the way that we've been discussing, that there's multiple components that are creating this experience. And whether it's you just had an acute fracture and a lot of nociception or information coming from sensations, and whether you're fearful, it's emotions or your thoughts or your beliefs, like all those things are contributing. So that's the one thing I kind of regret putting in there. And that's the one thing about us trying to teach, there's a lot of responsibility, I think, we have just in what we're doing here and trying to share our thoughts. But as clinicians out there, the things that you tell patients, it's, if you don't give more accurate, updated perceptions of pain with an informed pain perspective, then the hardest thing for us in society is to reverse that bad education,
Nobody's a blank slate, and trying to change a slate that already has had stuff carved in it pretty deep is tremendously difficult. But I would say on our end is, we're all learning. That's the thing, is
yes.
we may say something and it may change, but that's good. It means we continue to update and revise our information. And so at some point, I use terms acute and chronic and all that other crap too.
That's how people understand it.
It's even now, I'll sometimes use that language depending on the audience. I try to put a caveat on there saying I'm using this because of this audience, and this is, anyway. So I don't want you to feel guilty, Dr. Cady. It's okay.
No, that's okay. That's why I need to do a second edition.
We're all human. Yeah.
That's right. That's right.
Yeah, the updated version. But
yes, and then maybe I'll have you, peruse it for the audience as well.
No, maybe I can write the foreword. I would love to do that.
Oh, yeah. Well, see, now you've just booked it. You're gonna have to do it. So you're gonna really have to help me make sure that we're both in alignment. So let's see, the last one, the finale here. The last misconception is that explained pain throws out biology and biomedical models to focus only on the psychosocial. Oh, Lord. We know that's not true. The accurate conception is that explained pain is a pragmatic or practical application of the biopsychosocial model of pain, which integrates treatment of peripheral and central nociceptive drivers, or these sensations that people describe, alongside other contributions to pain. What do you think? You want to dive into that, or you want me to talk?
I think absolutely I agree with this, and I talk so much, I better let you say something. Otherwise,
well, I think it's hard. I have a lot of colleagues who still do pain injections, maybe not nearly as numerous as some other people, and it's really hard to make them go through this existential crisis that both you and I have gone through.
It's not fun. That's for sure.
It's not fun, and I can understand the battle within that. This is what they're taught. They to the best of their abilities without this kind of funded knowledge that we've been fortunate to be exposed to or sought out. I can understand how it would be really difficult, and I think some of them try to do the best they can. But I guess my feeling at this point, and I'm not quite as black and white on it, is that it's the context in which you try to help or try to serve people. And I think it is, yes, understanding explain pain is a wonderful way to have a good fund of the more recent pain science knowledge, so that you deliver things in a way, not necessarily to someone, but your care or your suggestions or the things that you do, that if it's not that I'm endorsing necessarily that someone does an injection, but I think it's paramount that we treat humans in a way that is humane and considers risks and benefits and acknowledges the limitations of the things that we are doing, not necessarily you and I, but that it's minimized, and that they recognize that there are a lot of other things that could help them, and they would believe in more if they would give it a try initially. And so this application they're talking about is looking at this big picture of this person's life, all the potential contributors to their pain, and integrating types of treatments that address maybe the things that are most relevant for that person. It might be heightened anxiety, a lack of sleep, various ways that they're moving or not moving. And so those are things that, I think ultimately Explain Pain wants you to have that fund of knowledge so that you treat this person in a way that really you'd want to be treated yourself. If you don't want to harm yourself and minimize the harm, and you want to be empowered. So I kind of went on that little tangent because I know there's a lot of people out there that might be watching this that probably do some things to patients, but my hope is that they recognize that there are limitations in what they're offering and that they strive to endorse the things that they may not get paid for, but really could help, patients get better.
Well, and that's a whole nother topic.
Yep.
To talk about there, because really what's the fundamental driver is what you're doing benefiting you, or is it actually benefiting your patient? Mm-hmm. And with this misconception, I often see is people will say, oh, well, you're saying if there's a knife stuck in my leg, then it's all in my head. And I'm like, well, yeah, I'm saying, yeah, if there's a knife stuck in your leg, then your pain is all on your head, even with a knife stuck in your leg. Well, what about the knife? Well, you're still going to pull out the knife. It's not like if you weren't experiencing pain, would you want to pull the knife out of the leg? Well, yeah, you're never ignoring the bio. And here's the thing, I'm not anti-injection. What I am is I'm anti-injection when the major therapeutic effect of the injection is not from what you're injecting or the injection itself. So if you are in a scenario where you have a large contribution of peripheral nociceptive information, so like a broken bit, like a rib fracture, let's say, mm-hmm. then it makes sense to diminish that peripheral nociceptive input through an intervention. But if you're having rib pain that's been there for 6 months and there's no fracture, then delivering an injection, if you're doing a rib block there, it makes absolutely no sense, because we know from the data that the main therapeutic effect for the pain standpoint isn't from the injectate. It's not that you're numbing up those nerves per se, is the fact you're doing on the central phenomenon where you're actually had the belief part about that, the people have a trusting relationship in there, or you're simply numbing up normal sensory inputs and you're changing that sensation in that area, and they're gravitating to now using that new sensation to construct a different experience around. And so what your therapeutic modality should fit the pain fire that you're treating, not you're going to somehow explain your pain fire in such a way to support the treatment that you want to give, right? And so that's a very different thing. So again, I'm not anti-procedure. I'm anti-procedure when that's not the major effect of the procedure itself.
Right. And go ahead.
I was going to say, and if the knife's stuck in your leg, pull the knife out. I don't care whether or not you're experiencing.
Unless it's like it's a budding, unless it's in the aorta, yeah, and if you pull it out, then you're going to bleed to death.
Yeah, so, just make sure you have large bore access, and yeah.
Yeah, it as in many things in medicine, it depends. It's never, and it's never always. It depends, and you want to have a good perspective and make sure that you're not missing something major. But we'll end on that note. I think in general, let me take this off our share here. Here we are back to us. I think these ideas of misconceptions, were important to point out because people were interpreting things maybe in a way that wasn't helpful. And negating or eliminating or thinking that it's just all pain science only. And then that even makes people think that it's in their head in a way that's not what we're saying. But we know that multiple things are important. Even, like we said, the gate control theory, it's one of many parts to the whole system. So we need to keep that in mind, that we're complex organisms with very just complex lives and complex situations, and that there are many things that can impact pain. And when we deliver pain science, it's not by injection. You're
not poking them with it. You don't poke with pain science.
Right. In fact, it could actually turn people off if you try to force it on people like that.
Well, that's the pain science vomit. That's, PSV is never, you shouldn't do that either.
Oh, that's another acronym now for the medical field. Great. But in essence, this is more hopeful in the way that it's delivered, in the sense that it's just a format or a knowledge or a fund of knowledge that feel free Dr. Kevin, if you want to speak on that. But I think that for a lot of people, it gives hope for the future and how we are trying to help people with pain, especially because unfortunately the opioid so-called crisis or opioid overdose crisis has created more attention towards pain, which hopefully will be the silver lining for delivering better pain care.
Yeah, and so the other part on that is, if for the critics who have these misconceptions or say these misconceptions or reinforce these misconceptions, really the question to ask, if that is you, or if you find information really challenging, or you're going to say, oh, Dr. Cade, you're an absolute idiot, or Dr. Kevin, you're a total ass. I know people say that. That's okay. But really the question is, well, why? What is it? How is it threatening you? Why is it that this is so dangerous to your paradigm? And again, all you have to do is questioning it and start examining that critically, rather than blindly believing that whatever that we're doing is the right thing and that everybody else is a bunch of idiots. And being able to have a little moment where you do some self-reflective thought, and what you think you know, do you actually really know, and why do you really know it? Because I know for me that went right in my fundamental crisis. I can remember coming back in 2000 and when was it? I think the back pain guidelines came out in like 2009 or something, and they were saying, oh, we shouldn't be doing injections. And I was at a conference, and everybody was up in arms saying, I cannot believe these people are saying we shouldn't do injections for back pain. They're a bunch of idiots. They're a bunch of hacks. They're all biased, and they don't know what we do. And rather than actually saying, well, maybe we actually need to critically examine the research data with an objective eye, not a subjective lens that we're viewing it through. And really we're reacting because that's what we did. That was our livelihood, and we felt threatened. And it's perfectly understandable. If your belief systems are threatened, they will react. They're designed to do that. But if we're going to be in a science-driven realm, or we're going to deliver care that is really aligned with the best evidence and data, and then deliver that in a way that it relies on a fundamental scientific method, then we have to be willing to actually question those gut reactions that we have, rather than just assume that, well, that's what they're saying about pain science. And I want to know, well, why are you actually saying that? And almost always you're going to find some other kind of there's going to be some self-interest. There's going to be either you're doing a technique that isn't aligned with the science. You feel like you have the magic hands, and you're like, I feel so good. And if somehow my magic hands go away, that's going to threaten who I see myself, because I see myself as the magic hand fixer, or I see myself as the all my injections work except for the people that don't work, and then it's their fault. So just again, folks, you don't have to change your belief systems, but you have to be able to curious about your belief systems, and be willing to at least challenge them a little bit. And sometimes you have to take a deep breath doing it. But anyway, why are you getting so reactive? Why is it that you may be reacting to these myths? I think is really, really key. I react to them, and I can tell you why I react to them, but we'll save that for another episode.
That's another episode.
That's another episode, yeah.
Well, you want to close us out?
Did I start this one? Well, I guess, okay.
I don't know. Well, did you start or I start?
I don't know. I'll just close it because I didn't close the last one.
Okay.
So anyway, this is the end of the episode, folks. Thank you for joining us. Again, Dr. Kevin here and Dr. Melissa Cady, the Challenge Doctor, with the Paindora Podcast, recognizing that out of that box that Paindora had, the last thing that came out was hope. And so with that, I'll just say stay well. And Dr. Cady?
And to more joy.
All right, everybody. We'll see you later.
Bye-bye.